2024 OEBB meeting. We'll start by having a roll call to see who's here. Enrique, Michelle, Bill,
here.
Susan Miller, I think I saw you.
Present.
Sue Ricky Smith,
Here.
Bonnie Lucy, Robert Young,
Yes, I'm here.
and I'm here. So that's 1, 2, 3, 4, 5. Enrique, are you on? And I see Michelle, you're saying you're here. Enrique, have you joined us yet? Yeah, thank you. We are one person short of a quorum. Enrique and Bonnie, either of you here? Okay, so I'm going to postpone the approval of the minutes. We will go ahead and get started. And Rose, if you can kind of monitor when Enrique or Bonnie arrive, we'll go ahead and have approved the minutes. So just in terms of introduction, we're going to be spending the vast majority of today looking at behavioral health care. And that's pretty obvious if you looked at the agenda and read the information ahead of time. It looks like we're going to start with a presentation from Mercer, in particular, Dr. Chuang, and then we'll be hearing from our two health plans. Kirsten, do you have introductory words, or do we go immediately to Ian?
I'm sorry, Tom, can I interrupt for just a second? Sorry, Kirsten.
Yes, of course.
Yes.
Bonnie sent me an email saying her husband was having surgery.
I saw that. Yeah, I saw that.
She
will be in and out.
Yeah.
Yeah. So we're still waiting. Hopefully, if we get Enrique, then we have a quorum.
Thanks, Rose. Tom, aside from wishing everybody a happy new year and saying it's great to see you all again, and we're really looking forward to kicking off the renewal process, I'll just pass it directly over to Dr. Chuang.
Thank you. Next slide. So as you can see, we're going to dive into some statistics around behavioral health. I think we've heard from the OEBB members that there's a need for the service. It's equally important as ensuring that physical health is available and high quality. Similarly, on the behavioral health side. However, the statistics reflect some increasing trends in terms of prevalence. And if we look at the national as well as Oregon data, there's parallel trajectories. So in 2021, in the US, it's reported about 23% of adults self-reported having mental illness. Oregon, of all the states, ranked third, reporting at about 27%. However, please note that Oregon as a state is #1 for the age group of 18 to 25. So the young adults as a state is first in the nation in terms of prevalence. It's important to note that also the rates appear to be going up. Obviously, with COVID, and then now post-COVID, we know the ecosystem and the environment has put some strain on the people, and the awareness, as well as the need for mental health care, has continued to increase. That being said, there are disparities in terms of how care is accessed, the availability of care, and that's why we want to get into network standards and how do we want to track and evaluate that, where rural and coastal communities tend to fare worse than urban areas in terms of the prevalence, but also in terms of access. Now, at the same time, teachers are stressed and burnt out. Similarly, healthcare providers are equally burned out and stressed. And there's challenges with availability of providers, just like primary care, behavioral health therapists, psychologists, psychiatrists. We probably have not enough clinicians relative to the population needs and the patient demand. So some stats and figures here, somewhat alarming in the sense that in 2022, only 51% of U.S. adults with mental illness received treatment for their condition, of which 50% almost did not receive, obviously, treatment. But more importantly, 26.6% of them sought treatment but could not find it. So there was a desire, a need on the members' part to seek care, but they weren't able to access. So that's of concern, and that'll be a big part of our discussion later today. Next slide. So for the next two slides, we're going to take a look at some stats and figures around mental health and substance use disorder. Mental health illness is sort of the catch-all for conditions like depression, anxiety, mental distress, schizophrenia, etc. It is not inclusive of intellectual and developmental disorders. Substance use disorder includes both alcohol use disorder as well as drug use disorder, and the drug use category is obviously very broad, illicit legal drugs as well as prescription-based medications. When we look at the behavioral health conditions, population-wise, about 84.2 million people, or about a third of the U.S. population 18 or older, have one or both mental illness as well as substance use disorder. So that's, a third of the population is not insignificant, and a small portion have both substance use as well as mental health. If you look at the proportion, it's basically half of the substance use disorder also have concurrent mental illness as well. So these individuals are hard to treat. They need quality care. They need access to care because of the complexity of their mental health overlap. Next slide. Specifically to substance use disorder, again, we're looking at both alcohol as well as drug use disorder. There's a smaller overlap, but overall, it's about 17% of the U.S. population's age 12 and older. And there's some criteria based on the DSM-5, which is the diagnostic manual for mental health care in terms of what gets classified as drugs within this context of substance use disorder. And then 11 criteria for misuse, ranging from dependencies to impact, social impact, personal impact, impaired, controlled, etc. So this is the statistics specifically around substance use disorder. Next slide. When it comes to the rates and the trend, again, the arrows show both increasing prevalence from pre-COVID to 2021, with Oregon higher than the U.S. average at just under 20%. Big jump from 2018 to 2019, almost a doubling, both at the national level as well as in Oregon. However, when we look at Oregon relative to other states, by age group, they're all in the top 10. So we see the various state rankings for young adults all the way through older adults for substance use disorder. Particular note here, 18 and 25, as I mentioned earlier, we're seeing a spike. Obviously, as Oregon is moving from the 10th ranked state to the 7th, there's an increasing rate of a prevalence disproportionate for this age group. So something to keep in mind. Next slide. When it comes to alcohol use disorder, again, Oregon's rate prevalence is slightly higher than the U.S. average. And similarly, there's been a doubling in terms of reported prevalence pre-COVID, 2018, 2019 to 2021. Again, when we look at the age group ranking relative to other states, they're you know, in the top 10, other than 18 to 25, which is at 11 ranking by state. Next slide. Specific to drug use disorder, the huge increase in prevalence from 2018 2019, tripling almost for Oregon, and that's of concern. U.S. average increased as well, similarly tripling, and for Oregon, of huge concern is that 18 to 25 age group, where it's basically second in terms of the state ranking relative to other states. So, something to keep in mind. Obviously, there's just some differences in terms of the prevalence, but overall concerning trends and trajectory within Oregon to keep in mind. Next slide. When it comes to the treatment gap for substance use disorder, and that's defined as needing but not receiving substance use treatment, the ranking is as follows. Again, there's a increasing occurrence or prevalence of this happening both nationally, but also a slightly higher rate for Oregon. And again, a doubling pre-COVID to 2021. If we look at it by age group, they're all within the top. Oregon is within the top 10, and slight increase jump in and ranking for, again, the 18 to 25 from 9th place to 7th. Next slide. When we look at treatment gaps related to alcohol use disorder, there's only a slight higher prevalence of occurring for Oregon relative to the U.S. average. But again, it doubled since pre-COVID to 2021. The highest ranking by age group is actually the teen, 12 to 17, moving from third amongst the U.S. states to number 1. So the young population, the young teens are obviously having issues with alcohol use, dependency, and abuse. Next slide. Okay, so if we're looking at the individuals age 18 or older regarding those receiving mental health services, Oregon has good utilization relative to the US. Obviously, it's commensurate to the higher prevalence. So we want to see increasing utilization of mental health services given the increased rate and prevalence. Specifically, when we look at it by age group, it's ranked actually among states number 1 for mental health care for the 18 and older broad category, but then specifically 26 and older, so is number 1 as well. So something to keep in mind. The need is there, and the utilization is similarly there as well. Next slide. Now, with regards to any mental illness, so this is all inclusive of everything, the prevalence for Oregon, again, remains higher than the US average. And where you look at the receiving of care, the 18 to 25 is ranked number 1 relative to other states. So something, again, just to keep in mind that age group is a high risk, and something to factor in when we're looking at network adequacy and addressing the needs of this population. Next slide. So the summary of of the prevalence rates. We have for 2022 US average, and it's showing continued increasing trajectory. We do not have it for Oregon yet. So the published data is lagging at the state level, but we have it for the US averages, and they are all trending upwards. So the expectation for 2022 data will be similarly increasing prevalence across substance use disorder, serious mental illness, alcohol use disorder, and any mental illness in the past year. So, a lot of need, and I think clinically behavioral health is just as important as physical health in terms of the impact on the individuals. And the reality is, it's hard to treat some of the physical conditions without the individual being in a good mental health state. Next slide. I think that is it. Rose, can I pass it back to
Thank you very much.
Kaiser?
Yeah, thank you.
Great.
Ian, thank you very much for the introduction. So Keith, are you going to lead off for Kaiser?
Yeah, I will kick it off. I won't be on camera today due to bandwidth issues, but we're pleased to be asked to provide this presentation on a very important topic. As we go through it, you'll hear many of the trends that you heard statewide are also reflected in our Kaiser population. As you would expect, with an integrated comprehensive delivery system, we have many parts of our mental health program, all of which are working in tandem, from inpatient to outpatient to pediatric to adult to geriatric, really across the spectrum of diagnoses and disorders. So very pleased to be co-presenting today with Michelle Teeples, who's the Senior Director of Mental Health, Behavioral Health, and Addiction Medicine, is a great advocate for high quality care, for patient-centered care, and for a health systems approach to these complicated issues. So with that, we can go to the next slide. Just a little bit of demographics. This is who we are. The data that we present reflects these members. We have 33, as of the end of 2023, we have almost 34,000 OEBB members. Just that number has really gone up year over year. A little less than half are subscribers, and the rest are their dependents. Each subscriber is bringing in 1.3 dependents for an average family size of 2.3. You can see the breakdown of children, adolescents, and adults, and definitely there are different needs in each of these population. And COVID the last several years has been a confounder or a co-determinant of those behavioral health status. There are traditionally a higher number of people who identify as female in the OEBB population, with 54.5%. That's been stable, but we know that in our world, people who present as female or identify as female are more likely to have mental health issues and seek care and get care for these issues. And the last number there is Enrollment Stability Index, which really indicates that our Kaiser members are Kaiser members through the years, with almost 95% kind of continuing coverage year over. So that's just the demographics of the population. Next slide, please.
All right, Dr. Bachman.
Michelle.
Yeah, I think I'll pick it up. Thanks, OEBB, for having us back again this month. So to kick it off around how the acuity of mental health conditions has changed, really the summary of this slide is it's a lot of social isolation that obviously occurred during the pandemic, an increase in the amount of time people spent on the internet and forming different kinds of connections. And of course, observing just the socio-political events that concurrently occurred with the COVID response. So I was having a discussion with our emergency psych services manager the other day, who manages all of the incoming ED for our substance use and mental health. And one of the things that she called out was really around, it's interesting because the time that people spent on the internet during the pandemic, researching, educating themselves, learning, various different platforms, let's be honest, everything from TikTok she hears to Instagram Reels to just reading published studies. people are presenting in the ED with more interest in wanting to understand their diagnosis. So we're seeing people come in with not in an actual crisis, but really maybe under the influence or having an event that led them to get there from a mental health perspective, wanting diagnosis. And of course, a lot of this is driven by the reduction in stigma. So Dr. Bachman and I were talking about just the journey that KP's been on to reduce the mental health and substance use stigma across our KP nation, but also contributing to more political platforms and just wanting to tear down those walls. So we believe that a large response to the increase in identifying substance use and mental health conditions is to people's desire to want to seek the help that they actually need. We're also seeing community conditions change, which changes the acuity of the mental health. So as mentioned around the socio-political events, there's staffing changes that occurred across our mental health. So I think it was mentioned in the previous slide, just the sheer number of providers that are available in these specialties. And our psychiatric community, which is probably the oldest aging population within KP of our providers, and there isn't enough of them coming up behind that group to supplement the demand that we're seeing in the network. Next slide, please. So, really, we want to go right into the emerging trends for the mental health. So nothing new here. We continue to see a rise with ADHD, autism, trauma-related disorders. A lot of people processing childhood trauma or finally seeking the care to process the childhood trauma. Functional neurological disorders. When we compared 2019 to 2023, we did see a rise. So very consistent with the data that was presented by Mercer around inpatient increases were really related to the use of alcohol increase, and then of course a depression increase. Our outpatient increases were around anxiety, depression, trauma and stress disorders, OCD, and I can tell you right now, one of the largest things that presents itself inside of KP is eating disorders. So it's one of the biggest things that we work with, not just our youth, but our young adults and our general population around eating disorders. So it is it existed before, but it's definitely been exacerbated by the social isolation that we've experienced. Transitioning from diagnoses that we've seen as emerging trends into treatments. So KP Northwest went live with our esketamine, otherwise known as Spravato. So this is a nasal form of ketamine that is for treatment-resistant depression. So we went live with that just over a year ago, I believe, and we're getting ready to open an additional location across the aisle in the Washington market to kind of relieve some of the pressure for the demand of services in procedural psychiatry in the Portland metro area specifically. So we'll start to widen the net on that. We've also seen patients seeking information about psilocybin. So this isn't new. When the VA went into their big studies around psilocybin, we started to get those inquiries then. It's not something that we're doing now in that space. And I would defer to Dr. Bachman if it's something that Kaiser Permanente or Permanente as our physician group is pursuing in the future. And then Brexalone for the treatment of severe postpartum depression. Dr. Bachman, is there anything you'd like to add here from emerging trends before we move to the next slide?
No, I think you comment about functional neurologic disorders, and I think we added that in there, and there is evidence of those increasing. I have a few patients suffering from those right now. And those are folks who don't actually identify as having a psychiatric disorder, but they are in a lot of distress, whether that's from chronic disabling fatigue, persistent dizziness or vertigo, neurologic syndromes like tremors or difficulty walking, or POTS, which is orthostatic hypotension, very fast heart rates when coming up and out. This came up because this was one of the manifestations of post-COVID syndromes, and they're also felt to be a manifestation of trauma and stress disorders. Challenging to deal with because it's not a straight psychiatric approach to it. Our occupational therapists and physical therapists do a great job, along with some primary care physicians and a few primary care folks who have really sort of taken an interest in this field. So it's not a huge volume of people, but I think it is something that we're seeing and is emerging. There's a greater, wider professional recognition of the issue of functional neurologic disorders.
Great. So we'll go ahead. Thank you, Dr. Bachman. Move to the next slide. And I think it's I'm going to hand off to you to talk about our depression, and then I'll talk about timely access when you're done.
Yeah, so this is just a diagnosis of major depression in our population. Although the level went up from 6.3 to 7.6%, that is a 20% increase in prevalence of major depression. And you can see that is just slightly above our regional average. So when we compared the OEB population with our commercial book of business, really all the trends were pretty much identical. Through the years prior to COVID and after COVID, OEB members and dependents have had just about a 5 to 8% increase in utilization of mental health services and diagnoses of mental health conditions. But we are seeing a significant increase from 2021 to 2023 here in the prevalence of depression. That's a formal diagnosis of depression that would qualify somebody for the HEDIS depression medication adherence metrics. On the right is a depression cost metric, which comes out of our DHCG analytic program, and that is all the accrued costs for members with these diagnoses of depression. But you can see the cost of it for each of the 7.6% of people who have a depression diagnosis. They account for more than 2x costs you would have otherwise attributed to that population. People with depression are more likely to present with other physical ailments and also have other physical ailments comorbid with their depression. We know costs when we have a member with depression are higher, almost about $910 a year higher. So if you just do the math there with the 7.6% of people with depression times the $910, that's about approximately $2 million of medical costs attributed to depression. So that's one of the behavioral health disorders that we're tracking, and one of the disorders that we've seen over the last few years increasing in prevalence and severity.
All right, well, I'll take it from here next.
Slide. Yep.
Awesome. Okay, so timely access to specialty mental health care. So you're looking at two metrics here. The one on the left side is urgent access within 48 hours. The one on the right side is non-urgent, otherwise known as routine, and seen within 10 business days. So again, to orient you, the bottom blue is the regional average for our book of business. And then the dark green line right above it is your Q4 2022 data. So you'll see that you're not much different from, and then of course you have the 2020 data that's above that. So you've had a slight decrease in members who get urgent access within 48 hours. But across the region, you are faring pretty well in this space. So as a regional target for KP Northwest, we set ourselves at 90%. For members to get access within 48 hours. We don't set this target at 100% because I'll be really transparent. If you've ever listened into the line when we're screening our members to determine their acuity, members will often defer their own urgency and say, well, that doesn't work because I'm headed out on a trip. So can I get my appointment in 4 days from now versus, within the next 2 days? Or so there is a member preference, believe it or not, when they'd like to be seen when they're calling in about mental health. I know that seems strange to wrap your head around, but this year so far in all of 2023, in totality, the data showing that we're between 90 to 95% of all members that are calling in are getting in within that 48 hours. So I don't see 2023 data reflected here, but that's part of the urgency around pulling this request. I don't think the data was ready for the 2023 summary at that point. So on the right-hand side, what you're seeing again, blue line remains the same as regional. Dark green is your 2021 and then, or 2022, and then all the lines above it are 21 and then 20. These are members who seeking routine care. So again, screening at the front doors from the point in which they call us for care to the point in which we see them within Kaiser Permanente. So it looks to be about 78.5% of your members are being seen within 10 business days. The NCQA target is 80% of members seen within 10 business days. We are a Monday through Friday operation, typically outside of the urgent needs. So routine care is that 10 business days in that Monday through Friday window. What I would say is at the end of 2022, KP Northwest did historically, and I have mentioned this before with OEB, have a triage process at the front door where we were helping to kind of guide members, but it felt like telling your story twice. So we had actually removed that entire process from our ability to screen our members for routine care. And so we're actually seeing members get into care quicker and faster, and they actually have a choice to use a KP provider. So if what we offer them inside of KP does not meet their needs, they are open to go to a contracted network provider within our KP system in the community. So that was a change. There felt like extra hoops and steps back in 22, but in 23, that barrier was completely removed, the paperwork barrier, I like to call it. And certainly members are able to access that. Next slide, please. We're going to go through the next couple are data heavy, so just hang with me as we move through them. Outpatient mental health services. So we will cover this for substance use as well, and you'll notice a really unique dynamic when we get into these discussions. The mental health services here do not include like any health and wellness, any digital therapeutics. This is strictly if you're seeing a therapist or a psychiatrist within my service line, or you're getting group care within my service line, that's the data that we're reporting here now. So again, blue lines and dark green lines stay the same. So that's your 2022 over the book of business. We're saying 90.3% of OEB members got individual visits only. 8.8% had group and individual, and only about 0.9% of patients had group visits only. So this data is really interesting as you look to see the difference when we get to the substance use slide, and you'll see the difference in how they utilize groups in a different way in the care path journey versus how mental health has it here. We did add an expansion in our group program in 2023 to include DBT. There's a huge demand for dialectical behavioral therapy within the community, and there's a huge backlog, honestly, with the Portland DBT Clinic in getting anyone into care. It doesn't matter if you're whatever insurance you have, there is always a wait list to get into Portland DBT. So we did expand our internal services to offer groups there. So we did see a slight increase in people having interest in that program, and we'll continue to build that out as we go into 2023 or 2024. All right, so
Michelle, do you want to just say describe what DBT is? It's really important what DBT is for folks who might not know what that is.
Oh, yeah. So Dr. Bachman, do you want to take that?
No, go ahead.
Okay.
I can. So DBT, two of the main therapy types. One is cognitive behavioral therapy, which is a very rational approach, has probably the best body of evidence behind it. It is typically used for both treating depression and anxiety. For people with certain kind of emotional conditions, which with high levels of lability and variability, often teenagers, some young adults, people with personality disorders, DBT is a different approach to it, kind of involves some mindfulness. It involves some understanding of emotions. It has some overlap with CBT, but it's a really kind of a different experience of insight into it and how to regulate and be less fearful of the emotions that somebody is experiencing. So it's often something that's used in teenagers. It's often something used to people with frequent suicidality, and it has applications with kind of across the spectrum as a different approach to CBT, which some people doesn't resonate with their belief system or their mental status. So that's a quick. DBT does have evidence and evidence basis behind it as well, but it works very well in a group setting.
Thank you, Dr. Bachman. All right, so outpatient mental health services on this slide, what we're looking at is really the visits per 1,000 in your membership over the total visits that they seek with inside of KP. So when we talk of the percent of all visits, this is your this is including your outpatient in your primary care, emergency room, surgical, lab, radiology. So anything you get within inside of the walls of Kaiser Permanente, the percent of visits that are mental health is that 14.1%. So the book of business average is about 13.
I think we need to advance the slide.
I'm sorry, I called for the advancement, but we got caught up in DBT. My apologies.
Yeah.
It is.
No, that's good. Thanks.
You're 14.1%. So when your members are seeking care inside of KP, 14.1% as of the end of 2023 Q3 was the totality of mental health services. So and I would say that's a significant increase over Q3 of 2022. You see there's about a 3% increase in that space. And again, I tie it back to just the reduction in stigma, the availability of services, the conversations we're having with people about the need to engage sooner in their care journey and not waiting for it to escalate to the point in which they're more acute and needing a higher level of care. So we're going to go ahead and proceed into the substance use pieces, and then we'll get back to some of the network standards conversations as we move through our presentation. Next slide, please. So the outpatient substance use. So again, I wanted to say, in the mental health one, we saw here from an individual visits, mental health was about 90% of your membership were getting individual, and only about 8 or 9% were getting group. What you see here is a symptom of the way the treatment looks a little bit different in substance use. So 57.7% of your members are getting individual only, and 40.7% are engaged in group and individual visits, with about 1.6% of your population that only had group visits. So what I like to say here, and what my clinicians have trained me on really well, is that the group component and the community elements of substance use and recovery really do come from the group component of it. So it is really important. They call it the candy to their care journey, is really to get them all in the same room, to get them within the same treatment and talking about their experiences, whether it be from a harm reduction perspective or from to be completely abstinent from the substance or through that whole thing. So it really is, the groups are a bigger component and more widely accepted in the substance use than they are actually in the mental health, at least what we're experiencing inside of KP. It doesn't mean we're going to not keep carrying group programs in mental health. It just means that we'll have to keep altering and kind of changing them to afford members the types of group care that they're looking for in the mental health wing. But certainly this is a good mix. You are slightly above the regional book of business for people who are getting both individual and group. And then of course, you're just slightly below individual visits for the region. All right, next slide. This slide is similar to the one that you just saw about mental health. So the totality of all visits inside of KP. So again, that 0.7% on the right side, which is your Q3 2023 data, is below the regional book of business for total visits for your members within KP. Are 0.7% of them are substance use disorders. I do, and Dr. Bachman, I'm sure, has some insight into this with the primary care side of the house. I do hear from my addiction medicine medical team and counselors that, you know, often members do screen. So there is a lot of screening that happens between primary care, addiction medicine, and mental health for substance use disorder. However, it's the member's desire or willingness to seek treatment. And there still is a lot of stigma around substance use. And so oftentimes, although it's been screened or maybe diagnosed, the member isn't at a point where they're ready to either abstain or go into any kind of harm reduction treatment. Dr. Bachman, do you have anything you want to add around that before I move on?
No, I think you said it very well there. I mean, that is a factor of the being on the behavioral journey, being ready to recognizing it's a problem and wanting to make a change. We do lots of substance use screening, and lots of people are using harmful amounts that have medical, psychological, and risk attached to them, and we let them know that. But if, hey, I'm not interested in treatment, that's just that gap is going to be there.
I see a hand up, Kristen.
But screening helps because
Kirsten, you had a
boost people. Hopefully, if we do it right, the screening with the right kind of techniques, talking to somebody that can move somebody along through the stages of change to get them prepared to be treated.
Yeah, sure. I just have a question for
Kirsten.
you, Michelle, and also Dr. Bachman. You know, something we've been talking a lot about over the last year, and I know this will probably sound familiar to you, especially you, Dr. Bachman, is the role of health coaching in reaching exactly this demographic that Michelle was mentioning, you know, which is, you know, ideally we're doing many different kinds of screening. This could be applied to substance use disorder screening, also cancer screening. But we do a screening, and then after the screening, if there's some sort of positive result that indicates, okay, there is a need for, you know, further testing or treatment, it is still the member's choice. And at that point, for members who aren't yet ready, we're just thinking about, does Kaiser have a process to funnel those members over into Kaiser's coaching program and then maybe recirculate them back to that treatment decision again a little bit later?
Yeah, so I can start. That was a great question. And then Dr. Bachman, please add in where you see opportunity. So when we do our screening, a lot of the screening happens, the majority of the screening does happen in primary care, Kirsten. And so from there, the physician group is aware that we also have behavioral health consultants. So these are licensed therapists that can also do screening for substance use and behavioral health. And they can refer to a behavioral health consultant to have further discussions with the member, either in the moment or at a scheduled time we strive for within 2 business days, and usually can find access within that time to be able to hand them off to. We also do provide digital therapeutics, meaning that there is that Ginger health coaching. I'll be really transparent though, the utilization, I mean, I think members, it's text-based. And so unless you're tech savvy, a lot of members aren't really interested in going into that realm, or some choose it and some don't. We do have health engagement and wellness coaches. And Dr. Bachman, those live more in the population health side of the arm of the house. So I don't know if you can speak to them or any other initiative.
The health coaches are available, and often they're going to help. Somebody's ambivalent about a behavior change, they'll do it. But if you think through it, like for mental health stuff, you're probably somebody's like ambivalent about getting therapy. Having them talk to a health coach, should I get therapy, is kind of probably wouldn't be that enthusiastic about it either. Or should I take a pill? That's something you're probably going to work through with your physician. So it's not a huge role, but for the stuff, the lifestyle stuff that can help a lot with mental health, such as sleep management, exercise, I think that's right in the health coach's domain. But they're the health coaches are real. They're not chatbots. They're humans that have, graduate degrees in nutrition or health education. So are really ready to have those conversations. But if it really became clinical, they would refer that back to the behavioral health team. I think that health coaches, the behaviorists, the behavioral health consultants, the BHCs often can act like a health coach because they can remind somebody or help them on the path towards better sleep or physical activity in the context of what they are presenting with, which may be anxiety or worrying or rumination or clinical depression.
So in short, we have our BHCs and then we have our health engagement wellness folks. So, and we utilize both to a high degree.
Yeah, it's great. Thanks.
You're welcome. All right.
And there's always room for better handoff, better transitions. Everybody reminding all of us what resources are out there and making it accessible to members who also have direct access to all these things as well. So always there is room for improvement.
All right, next slide. Okay, so we're digging into our network access limitations. So as always, and what I've presented before when we've done presentations around network adequacy is really CMS has their time and distance standards that we're all aware of. And then as many presentations before, we've also talked about just making sure that we meet the member from a provider modality, gender, in-person care, virtual care, all the pieces that maybe don't factor into CMS's time and distance standards, but we're looking for network access that provides timely treatment without delaying care. So in the Northwest, in KP Northwest, if treatment options are limited in the immediate network of contracted providers, i.e. it would result in a negative outcome, or there are closed panels, then we will contract with facilities outside of Oregon and Southwest Washington to ensure timely access to treatment options. So it's different than if a member does research and finds a facility they want to go to that we're not contracted with. We don't typically, those can go through the appeals process and the member can actually request by their evidence of coverage language. But typically, we do have a list of providers that we don't have core contracts with, that if we do exceed the capacity within our existing network for whatever reason, we can flip over and do single case agreements in those cases to ensure that the member gets care timely and most importantly for the treatment they need. So patient preference. And so I included this bullet here for just as a reminder to folks that, it can drive a delay in care when a member is seeking a specific provider. So if a member came in and said, I only want to see Dr. Bachman, but Dr. Bachman, it has a full caseload, and they're willing to wait, that does drive their own care delay, even if we're saying we have these 7 other providers or these 15 other in the network that can see you tomorrow for EMDR. And I know Dr. Bachman doesn't do EMDR, but as an example, there is a patient preference that does drive that. And I will be transparent that data, unless somebody has figured out how to extrapolate that from the data base points, member preference can drive data to look skewed because somebody could be offered an appointment within 10 days, but be seen 15 days because of their desire for modality, gender, day of the week, time of the day, etc. Call it out just as a quick reminder to folks that it does drive that. There is a component that is driven by the member as well. So what are we doing to improve in-person mental health treatment? I just want to say with the pandemic, happening, it did provide us the opportunity, obviously, to operate outside of our normal boundaries, meaning we typically hosted things like intensive outpatient programs only in person and only in Portland, which was a barrier to a lot of our members, whether it be adolescent, young adults, and adults in general. We widened that net during the pandemic to provide virtual care, and frankly, the members glommed onto it and love the intensive outpatient programs. We actually have members that are in rhododendron. We can get members that are down in the Salem area that maybe historically have used outpatient contracted providers. They can participate in the actual Kaiser Permanente programs that we have inside of KP. So transportation does continue to be the largest barrier to members participating in treatment, specifically in substance use too, and also sometimes it's a safety mechanism, right? Some of our members that are seeking treatment are intoxicated and can't drive, and the last thing that we would want them to do is to be driving at that point in time. So we do continue to offer 50% of all of our appointments in our departments in person. And the member really has a choice when they get on there to book. Some of them can be converted from virtual to in-person. It depends if the provider's in the office. We are looking at hybrid groups. So it is shockingly difficult to engage people on a video as well as in a classroom setting with one clinician leading the entire thing by themselves. So we are dabbling a little bit more in hybrid groups in 24 for therapy and addiction counseling. And hopefully we'll be able to find the sweet spot there. We are continuing to prioritize contracts with in-person. So what we saw pre-pandemic obviously was a ton of brick and mortar because people didn't fundamentally have the means to provide that, nor were people as open to virtual care. In my personal opinion, we had a virtual program. It was probably used less than our in-person care was. But we've been more heavily trying to recruit in-person brick and mortars, especially down in like our Eugene area, Mid-Valley, but really across the entire Oregon and Southwest Washington to ensure that we have that good solid mix of providers. But they are hard to find. I'm not going to lie. And I don't think Moda would say that they're not struggling to find the brick and mortars as well. So then providing behavioral health consultants. So we just talked about our behavioral health consultants that are embedded within our primary care teams for that interdisciplinary component. They are in person. There is always somebody in the office at the sites that we have BHCs at least 5 days a week. But all of the behavioral health consultants work 75% of the time in person, and then we still have virtual options for them as well. Next slide, please. Dr. Bachman, I'm going to turn.
Yeah, the BHCs are really part of our primary care behavioral health integration that is talked a lot about, but is pretty actually rare in the field outside of FQHCs. I know Providence has been doing work in that space as well. So I think we're pretty fortunate both for OEB and PEB to have that higher level of primary care to behavioral health integration. There is such a drop off between when I see somebody and there's a problem assessed to getting them treatment. So the sooner you can get it, the sooner you can sort of formulate the problem, the sooner you can offer somebody treatment, you're giving them hope and you are raising their likely successful outcomes. This slide here is data related to primary care screening for substance use, anxiety, and depression. We sort of developed a nice automated model where somebody can screen out. They get an email or text within 24 hours prior to a primary care visit, at which point they do really just a few items for each of those. And if those are negative, then it kind of takes care of it and we don't need to bring it in the visit. If it's positive and somebody is endorsing significant depression or significant alcohol use or anxiety, then we can do more detailed assessment in the office. And it's not uncommon. Someone is there for an ankle sprain, someone is there for a persistent cough, but there is the other thing going on that primary care clinician in conjunction with a behaviorist can sort of initiate treatment, provide options, and help with next steps. The anxiety screening is something that you'll be hearing more about. There's now USPSTF recommendations for anxiety screening in primary care, and we'll see the numbers for that go up. This screening program, or the primary care screening, is consistent with our CCOs in the Oregon Medicaid program, but we thought it was really appropriate to put that throughout the system and not just do that in our Medicaid population. Question, Tom?
Yeah. Do you think this has a lot to do with the increasing prevalence, the fact that you're screening more, or not so much?
Oh yeah, I think that's one of the things. I mean, I think it's, look at the data of the increasing prevalence, increasing use. It's a few things: it's screening, it's population need, and it's access to care. So I think it's part of it. It brings it in, and so there will be a lot of people who are picked up who some aren't ready for any kind of treatment, but some are, and so I think that's part of it. Yeah, we can go to the next slide. I thought,
All right.
We've been doing a little less asking about exercise, which is still so important, but I really think the time is right. I don't feel this is time not poorly spent in the office when we start having dialogues about mood and about anxiety and about suicidal thoughts if they're present, and about both healthy and less healthy and harmful.
All right.
Time well spent, even in a time pressured environment. Turn to you, Michelle.
Awesome. Thanks, Dr. Bachman. All right, complexity of services changing. So I'll give you a little, I'm not sure everyone is briefed on the different steps of care or levels of care. So I noticed I left an acronym on here, so my apologies. So typically on this slide, we're going to be talking about our intensive outpatient programs or our partial hospital programs, otherwise known as IOP and PHP. And these are step down levels of care. So if you're coming out of inpatient, sometimes you go to residential. If you're coming out of residential, sometimes you go to a partial hospital program. And sometimes from a partial hospital, you go down to an IOP and then down to traditional therapy or group settings in more of an outpatient environment. So they are considered higher levels of care. There are more facility-based, and then there are community-based care programs. Inside of KP, we have an intensive outpatient program service that spans our adolescents all the way through our adults, and we have them in both mental health and addiction medicine. What you're seeing here, though, is very specific to the mental health department. And just to orient you, there's a lot of data on the slide here. The top box that has internal and external, the little red squares. So the top red square, number 1, is really the completed visits in 2020 that we had related to intensive outpatient treatments that we provided inside of KP. If you go to the bottom box, it is the same top number, that 6,839, but it is the totality of the treatment that we did in 2023. So you can see that we had a significant increase for our intensive outpatient programs, hence why we also expanded our program going into 2023 and added providers and clinicians, knowing that the diagnoses and the treatment and the level of interest in intensive outpatient programs was growing, and the capacity within the network was shrinking. So obviously you can see in my footnotes up above that access to providers in the community is a real challenge. We do not offer a partial hospital program with inside of KP. Those programs are very intensive. They do require a 24/7 availability in a setting. It is something we will be exploring in 24 for potentially a 25 launch. But you'll see that bottom red box in the top bracket is the partial hospitalization at 1454 for the completed year of 2020 to a 1663 in 2023. All partial hospital programs are provided in the community with contracted network providers. So sometimes it's Providence, sometimes it's Rainier Springs, sometimes it's Cedar Hills. It just depends on where the member is stepping down from or what their level of care is needed from the mental health side or the substance use side. So all that to say, we are seeing an increase in the utilization of these services, but it is great. It is not residential level of care, so it is still very much an affordable level of care, and it does allow the member treatment options both virtually and in person, so meeting the members where they are. Next slide, please. So this slide is around inpatient admittance rates. So this is, we do not have an inpatient unit at KP Northwest. So we do have a residential program and a residential facility, but this is not data that's reflective of that. This is actual utilization of inpatient facilities in the community that we're contracted with. I think everybody knows the availability of inpatient psychiatric beds in the community has not kept up with the increase in demand over the past few years. And what we have experienced and what we're seeing, and just to orient you to this slide, that top gray line is the commercial membership. So this is bracketed by lines of business. So that very high line is the commercial. And what we're seeing is that the length of stay is actually increasing in 2023. So our average length of stay during kind of I would consider the height or the core of the pandemic was about 9.4 days. But right now, the average length of stay for psychiatric inpatient care is about 13.89 days. So that is an increase since, the pandemic. And of course, the increase in stay, I mean, there's no higher level of care once you get past the state hospital has, obviously everyone knows the challenges with the state hospital and moving members into that level of care from an inpatient unit, and how restrictive that is at this point. So we are seeing longer lengths of stay, and really nothing statistically significant about the demand. It seems to be kind of following a typical trajectory with a slight increase towards the end of this last year. Dr. Bachman, anything you'd like to add from your perspective?
No.
Okay.
All
right. Yeah. I'm going to go ahead and move you to your core data, focusing on average length of stay. So next slide, please. So specific to the OEB membership here, again, it's per 1,000 members, your inpatient admissions per 1,000, and then days per 1,000. Your average length of stay. So again, book of business is the blue line on the bottom at 10.8, and your membership who did access inpatient level of care service, they stayed an average of 11.3 days. So just slightly over what we're seeing for our traditional book of business, but definitely at a higher rate. You can see that's very reflective of the previous slide where we're talking about the totality of every line of business. From 2022 to 2023, you saw that jump in length of stay from 9.9 to 11.3 with your population. Next slide, please. So for substance use inpatient, so these are recovery units, medical detox. So again, book of business over your population, and your population has seen an average length of stay of about 10.5 days. Which is just slightly over the normal, but then less than the 2022 Q3 results. So just a little bit of a decrease in that space, and nothing at this point statistically significant, but definitely something to keep our eye on as we move through. All right, I'm going to take us to the next slide. So this is about our ED visits for mental health issues. So the top left is ER visits per 1,000, and this is a combination of mental health and substance use projected from 2019 all the way to 2023. And the right side is the outpatient visits, so our ambulatory per 1,000, also with the same data range. So the general summary from the ER, the green box, is that we are seeing a reduction, an overall reduction in people presenting to the ER. And there's a couple things that play into that, and we'll get into that in just a moment. But what's really nice, and as a leader in the mental health and addiction medicine space, I always want to say I don't want my members, if they don't have to present in the ED, because sometimes that can be more traumatic for them to experience the emergency department, or to call 911, or to have episodes where they've got more emergency personnel versus a more scheduled and targeted approach to either their harm reduction or their therapeutic engagement. So you're seeing on the outpatient side, we've seen a significant increase in outpatient visits, and that is around the mental health and substance use, which is great because it means that we've started to widen the net and capture people earlier in their care journey, earlier in their mental health and their substance use issues, and we're catching them in the outpatient and they're less acute at that point, or we can help them stay less acute by catching them sooner. So I really feel that these two slides together speak to the way that we're trying to address admittance rates or utilization of the ED. So again, we want to ensure adequate outpatient services, whether that be staffing my internal KP teams to the maximum capacity in the space that I have, or looking at network provider contracts that meet the time and distance standards, as well as the ratios, as well as what we need to do for modality and treatment. Adequate inpatient availability. So again, the inpatient availability is really driven by the communities in which we contract with. And I would say, I didn't list it here, but Residential, so we're huge advocates for continuing. We have our own residential treatment program, which is a 40-bed unit that's only available to KP members, that does mental health, addiction medicine, and detox. And I just think it's really important that we call that out as one of the things that we have available. Carrying contacts, I see I'm right at 2 o'clock, so I'm going to kind of fast track my way through this last slide. Carrying contacts, we make contact with members that present to the ED following a mental health or substance use as a regulatory requirement, but also to encourage them to engage in treatment. Go ahead and go to next slide. Inpatient versus outpatient. These are just general definitions here around what's considered out of network versus in network. Out of network is just defined as anyone not contracted with KP to provide the services. So there are a lot of therapists on Psychology Today that say, I will take KP insurance, but they are actually not formally contracted with us. So it's really important that membership validate that they're contracted with us before pursuing it. That's where we get in a little bit of a pickle. From inpatient or from in-network, it's really anything that you see down below there that is provided by a contracted provider or is inside of the KP 4 walls that we have in our provider network system. I know I moved fast through that, so post board meeting, if you have follow-up questions, let me know. The next slide is around, go ahead and move to the next slide for me. This is pediatric adolescents ABA services. This service line doesn't report up to me, but I am reporting out for the group. Just to get to the nitty gritty at the very bottom, OEB specific data saw 114% increase in utilization in ABA services from 2019 to 2023. So our total book of business for KP has about 700 patients in service for ABA autism services. These are done entirely in the contracted network. So we keep a very healthy group of network providers that can provide for our members in this space. We don't permit wait lists here, which is applauded all the way around. And then we do audit the quality of these providers 2 times a year. So there definitely was an increase in your utilization in that space, which is consistent with what we talked about earlier. And then lastly, our last slide, just to wrap things up for you. I know you know this, I know I've brought this slide before, but end-to-end, the healthy lifestyle, self-care and wellness tools, all the way to our inpatient contracts in the network and our emergency services 24/7 are just a small subset of the things that we offer. We have other programs such as medication opioid use disorder access in primary care. We have an OB substance use partnership with addiction medicine. We have persons with lived experience providing support for our members. And of course, we have procedural psychiatry and then a heavy emphasis on our equity and anti-racism and just the training of our groups to be more racially diverse and understand trauma-informed care. So I know I didn't get to go through everything, but I really appreciate the time. Dr. Bachman, do you have any closing comments or thoughts?
I have nothing to add, but happy to take questions online or offline as they come. Thank you for this opportunity.
Any questions? Well, thank you very much, Michelle and Keith, for your very instructive presentation. We have, I'm going to circle back. We now have a quorum. So before we move to MODA, I'm going to entertain a motion to accept the December 5th minutes from the board meeting. Is there a motion to approve?
I move to approve the minutes of the December meeting.
I'll second, Bill.
Thank you, Enrique. Thank you, Bill. Okay, all in favor, say aye.
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 Opposed? It approved. Okay. Sorry for that interruption. Now on to MODA. I didn't see who's going to be leading this off. Erica, are you going to be giving us introductions?
Yep, I'm going to get us started and then I will pass it over to Dan. So first off, just thank you. Yeah, thanks, Tom. And thanks everybody for having us today. We're thankful to be able to talk about behavioral health, especially on the impact on our members since COVID. So like I said, I will be passing it over to Dan Thoma, our Director of Behavioral Health, who's going to walk us through the presentation. Dan?
Thanks, Erica. as Erica said, we really appreciate the opportunity to be here and share with you some of the things that that we've observed related to your membership. So all of the data that we present here will be OEB specific data. So a few things that we want to look at, what's changed since pre-pandemic, looking at prevalence and acuity, looking at utilization trends, both in network and out of network and at different levels of care. Get a little bit of a peek at the impact of the Behavioral Health 360 program, which is available to OEB members for the first time in this last plan year. And I believe we'll be reporting in more depth on that at a future meeting. And also, as Michelle did, talk a little bit about industry trends, so what we see happening in the world around us. Next slide, please. So, as has been made abundantly clear by the two previous presentations, the world around us has changed related to behavioral health. So we're seeing increased prevalence and utilization. There's been an explosion of virtual care or telemental health care and substance use disorder care as well. We have, along with the explosion in virtual care, there are tons and tons of venture capital-based startups in the behavioral health space, which is something that prior to about 3 years ago, never seen the likes of it. But it's really changing our industry very, very quickly. And I think we will continue to see changes related to that over the next 5 to 10 years. We have introduction of Behavioral Health 360 for the OEB membership. Super excited about how that program has served members in the past year. Going to talk also about feedback-informed care. This is an established best practice. If you've heard my presentations before, you'll probably roll your eyes when I get to that part, because I like to talk about that. And also talk about some of what we're doing related to value-based contracting. So let's go to the next slide. Okay, let's start out with prevalence. Again, this is OEB membership data. And what we did is we looked back to the first, or to the last full OEB plan year prior to the onset of the pandemic. So that was the 2018-2019 plan year. And then track that all the way through this most recent plan year. One note on the 2022-23 data is that we're still in the well, just about run through the end of the run out period, but might see a little bit of, if we were to look 6 months from now, might see a little bit higher numbers on some of these things due to claims run out. So what we're seeing in the prevalence data in our claims, so these are any claims with a mental health diagnosis anywhere on the claim, is consistent with what Mercer presented to you earlier and what Kaiser said pre-pandemic to post-pandemic. We saw about a 4.5 percentage point increase in the prevalence of mental health conditions. What you see if you're looking at national data and some of the national survey data that came out in right at the height of the pandemic, second half of 2020, earlier in 2021, is you really saw an immediate spike in people self-reporting symptoms of mental health. And we don't see that as much, that immediate spike in the 2019-2020 plan year. Shows up more in the 2020-21 plan year. And I think that may be related to, particularly early on in the pandemic, it was, everybody went home with no notice, no preparation, and it was particularly difficult for folks to access care. That's still an issue, starting to ease up some, but you didn't have this increase in access proportionate to the increase in what people were experiencing early on in the pandemic. Let's go ahead to the next slide. With substance use disorder prevalence, we also see an increase from pre-pandemic to post-pandemic. Actually, a dip in 2019, 2020. Again, I don't think that was related to actual decrease in prevalence, but disruption in access to care, probably most likely. And then as that started to recover, you see the bounce back in the prevalence. One of the things that really strikes me about these data, and I think this is consistent across payer data, is that when you look at this roughly 1.5% prevalence of substance use disorder in our claims data, it's just vastly, vastly underreported versus the 17% or so that you're seeing from Mercer and that you'll get from national surveys. And so that really gives us pause to think, what's the deal with that? When we're looking at the mental health prevalence, our 27% was not too far off from what you're seeing in the national data. When you're looking at substance use disorder prevalence, what we see in claims is just, an order of magnitude below what you're seeing from when you dial up, when national researchers dial up people randomly and call and ask them about the symptoms. I think the stigma is one of the contributors to that. And along with the stigma, it's like, I think it's decreased faster for mental health than it has for substance use disorder. And I think that providers may be still more reluctant to report a substance use disorder diagnosis on a claim if that's not the primary reason for seeing the patient. You also see a really difference in help-seeking behaviors with substance use disorder versus mental health. So in mental health, the suffering is very much commensurate with the diagnosis. So if I'm depressed, I'm suffering from that depression. If I'm anxious, I'm suffering from that anxiety. And with substance use disorder, looking again at, if we look back to the 4 categories of problems that people with substance use disorder experience, those problems aren't actually directly related to their experience of using the substance. So if I am using alcohol or marijuana, that actually makes me feel good. That doesn't feel like a problem. The problems are secondary related to the use in terms of physical dependence, risky use, social problems, and impaired control. Those are all things that sort of as an outside observer, we can say, yeah, that person has a problem. But if I'm the person with a problem, the actual use of that substance feels good. And so that becomes a barrier as well to seeking care. So anyway, I think we have a lot of work to do in terms of getting what we can see in claims and in people seeking care to be closer to what we know the actual prevalence is out there in society. Let's go to the next slide. So we're gonna look a little bit closer within some of the mental health diagnoses and look at some different indicators of severity. This particular slide surprised me a bit as well, because we hear a lot about the increase in depression since the pandemic, and increase in isolation, which logically would correlate with increase in depression. And what we're seeing, we've got that spike in the 2020, 2021, that's a lot of 20s, plan year, but we're not seeing a huge increase, actually seeing a little bit of a decrease in the diagnosis of major depression. So in this slide, we actually took 3 different conditions as sort of proxies for severity. At the top is major depression. So that's going to be your most severe cases of depression. The middle line, the gray line, is adjustment disorder. And that's going to include people with depressed mood, people with anxious mood, people with mixed anxiety and depression. But it's a pretty decent proxy, I think, for the milder depression. And then the bottom line, the plum colored line, is persistent depressive disorder. That used to be called dysthymia, and that's persistent low-grade depression that lasts typically for years, and not seeing much change in that. So really quite surprising to me when we hear how much depressive symptoms and mental health symptoms have increased, and we look at the overall increase in prevalence, to see that our prevalence in the depression diagnoses has not really gone up appreciably. I should also mention, I always want to say this at the beginning anytime I give a presentation, but if you have questions, please feel free to jump in at any time. That tends to be more relevant to address them right at the time than try and come back later. Let's go on to the next slide. And we see a different picture here with anxiety. Here we're seeing the increase in prevalence of anxiety conditions and increase in severity of anxiety. So again, reporting on 3 different conditions related to anxiety. The top line is generalized anxiety disorder, or GAD. And that has gone up a lot since the 2018-2019 plan year, and gone up pretty steadily. Middle line, again, is adjustment disorder. That's actually the same middle line you saw in the last slide, and I'm keeping that there as sort of a baseline comparison. And the bottom line, the green line, is post-traumatic stress disorder, and we're seeing an increase in the prevalence of that as well. So with anxiety, we've got for the milder forms that are represented here by the adjustment disorder, you've got a pretty flat prevalence. But for the more severe forms of anxiety, the generalized anxiety disorder and the PTSD, we're seeing an increase pretty steadily from 2018 to 2019. One thing that I would say, to the extent that we can make meaning of that sort of disparity that we're seeing between the change in depression, change in anxiety, is it may be a bit of a hopeful sign, in that the features of depression are more associated with things like hopelessness, helplessness, giving up, feeling like I can't do anything. And anxiety, there's more of a feeling like I need to do something. And so, we look at the stressors that are impacting folks with climate, with the political situation, the deterioration in trust in our institutions. To me, it's a more hopeful thing to see that people are feeling anxious about this than if they were feeling depressed and giving up around these stressors. So I think we have a resilient OEB population. Let's go ahead to the next slide. I put this one in here just as sort of a reality check, perspective check. This includes some of the same data that Mercer reported on earlier, but what are we looking at in terms of the prevalence of anxiety and depressive disorders? This slide doesn't have pre-pandemic in it, but pre-pandemic, according to KFF, was 23.8%. So there you're really seeing that incredible spike beginning around April 2020, and then seeing a little bit of a leveling off since there. So a little bit of a different trend that you're seeing nationally versus what we're seeing in claims. Hopefully some of that claims data is reflecting improved access to care as well. People identifying with it and seeking care and engaging in care. Go on to the next slide. So we've already covered some of this, but just in terms of how do we make sense of these data? We've got the isolation, the political environment, climate, all of these things are increasing anxiety for folks, increasing stress. We didn't see the claims spike in 2020 that was reported in terms of the incidents, but we're seeing that we're catching up basically in terms of our claims experience. We're catching up with the increase in prevalence that is being reported nationwide. Okay, let's go to the next slide. And we'll talk now about utilization, looking at this from a number of different perspectives as well. And this one is going to be our biggest mystery of the day for us in terms of the MODA data. And Enrique, it looks like you had a question.
Dan, you had a question.
Yeah, that was me. Is that okay, Tom? On your previous slide, I'm trying to look at it on the packet. I can't see it, but my question is, the part of climate on the data, was that specifically to like climate change, like the environment conversation, and like that sort of anxiety that is caused among society to have that anxiety, I guess, or sort of depression because things look so dark, sound so dark? Or is it different climate, like political climate, you know, the political election, the Trump, or I mean, can you clarify that for me?
Yeah, that's a great question. So all of the above. So that, you know, the political environment is definitely a stressor, regardless of what a person's politics are. Wrote an article this morning talking about the well-documented decline in trust in our public institutions. You know, trust is lower in government and education. It's like people don't trust what's going on in our society. But then in terms of climate, in Oregon for like the last, 4 summers or so, a lot of people being affected directly by wildfires, being affected by smoke from wildfires, as well as that larger anxiety of, you know, what's the future going to look like, and now people actually seeing. I remember when people talked about, you know, when climate change is going to happen and when it's going to be noticeable, but we're seeing those effects directly, both in terms of temperature, in terms of the wildfires, and the effects that it has on communities. Ali.
Thank you.
Yeah.
Thank you very much. So with regard to isolation, so with OEBB, it seems like, you know, most of the employees are at work and working with others, different from PEB, which, you know, a majority of employees are now teleworking. In this context of OEBB, do you see or define isolation as really isolating themselves maybe in their personal time from others because of some of the things that you just talked about, or something else?
Yeah, good question. I was thinking more in terms of particularly that isolation that came early on in the pandemic when even teachers were teaching from home. And so not getting the normal social exposure. And as far as that second aspect of it, I don't have data on that and how different people in different populations are reacting to that, but particularly people with more chronic illnesses are likely to have restricted their social activities more out of ongoing concern about, about the effects that, because COVID is so much more severe if you've got other ongoing conditions.
Okay, thank you.
Yeah. Okay, so here's our big mystery for the day. What is going on here in terms of applied behavior analysis? Coverage for ABA started, if I'm remembering correctly, is around 2015, 2016, maybe. And there weren't very many providers at first. And what I have expected to see, I'd actually like to draw these data numbers back a couple of years earlier. But I think you would see if we went to like 2017, 2016, lower than that 7.8. So we saw it go up and just spike like crazy, 4 to 5 times the amount of utilization in the 2021 plan year as the 18-19 plan year. And now it's come back down. So what is going on with this picture? I spoke with our care coordinator who specializes in ABA and helping families access these services. And we came up with a couple of hypotheses as to what's going on. One is that in 2020, when teachers went home and workers all over the place went home, there was more availability, and kids were at home. There was more availability from the side of the parents and the kids to engage in services. In addition to that, ABA, which for the most part had always been provided in person, a lot of that switched to telehealth, and telehealth lowers barriers to care. So we think that combination of sort of more availability, kids not in the school, kids in the home, and reduction of that barrier related to telehealth probably drove that utilization way up at first. And so we're seeing a bit of a return to trend, maybe. I fully expect this will start going back up again. But another thing that our care coordinator mentioned to me is that there's also been changes in terms of the providers. We had a major provider card leave the state of Oregon completely. So that affected the availability of services. And she's also saying that providers are reporting they're having a really difficult time attracting and retaining high quality technicians. And the technicians are the ones who are spending all of those hours with the children, with the kids, providing those direct services. And if you don't have the technicians available to provide those services, or if you have high turnover among those staff, then that's gonna make it more challenging to provide the level of service that might be clinically recommended. Let's go to the next slide. Okay, we see more of an expected trend here with just total outpatient mental health and substance use disorder. Again, we're looking at about a 50% increase from the 2018-19 plan year to the present. So significant levels of increase there. Let's go on to the next slide. With mental health acute inpatient, looking at admissions per 1,000 members, it's going up a little bit, not as fast as outpatient services, which would like to see the outpatient going up and the inpatient going down. Not seeing that at this time, but it's holding fairly steady. Decrease there in 2019-20. Again, hospitals were shut down. Everybody was shut down during that time. Let's go ahead to the next slide. So here we're comparing in-network versus out-of-network utilization. And we started out in this reporting period at just about 10% of out-of-network utilization. And we're seeing an increase in-network utilization and not seeing much of an increase in out-of-network utilization. We have been aggressively expanding our panel. We also increased our reimbursement rates significantly for behavioral health providers within our network. We think that has helped with retention and recruitment of behavioral health providers. Then in the 22-23 plan year, I'm going to point this out. I think this is a fantasy on my part, but I'm going to attribute the decrease of 0.2 of a percentage point to the availability of Spring Health and the behavioral health champions in helping members get ready access to in-network services. So I'm hoping that we will continue to see a decrease in the percentage of out-of-network services. And we can actually see we reversed the trend from the past 2 years there. So this may be related to the Behavioral Health 360 program. We're just going to have to see more data and be able to compare it with some of our other groups before we get a clearer picture of that. Let's go to the next slide. Okay, here's another one where it's early to draw any conclusions, but the very first data point that we're looking at, I'm finding pretty hopeful. And Enrique, did you want to comment or ask a question?
Yeah, if I may, Tom, Chair. So I'm assuming the out of network on the previous slide is because it's so low. Is it because we have the providers for access for our members? But I see a trend of an increase, slightly a small percentage, right? So per thousand. So I'm assuming if you can draw a detail or simplify that for me, like you see an increase of the out of network because members are not happy with the plan. They want what we're not offering, because if we continue to see the increase, then that's something that we should be prepared, 5-6 years out, and not address or not create a problem. We can prevent it in a way. But I'm also happy that we have good policies that allows members to utilize the network. So I was just wondering what's your analysis on that, or what can we do to provide or be more flexible for out of network? Because all those thousands of members are paying extra or going out of network because we're not facilitating that. So what can we do? What's your expertise on that? That's a great question. There's a number of things driving that. I would say probably the thing that's driving that slight increase overall is just it's following the overall trend of utilization up. So again, like the proportion of in-network services less, but people are accessing more services both in-network and out of network. So that's one thing that drives it. That drives the trend. But in terms of what drives out of network utilization more generally, it's typically a combination of the availability of in-network services. We know that's been really challenging. Then there may be specific providers that members want to see. And there's a number of providers out there, particularly in mental health. This is one way that mental health is quite different from medical. A number of providers who just say, like, I don't work with insurance. I have a cash practice, and because it's just their life is simpler. They may get paid more that way. So some of that is driven by member preference. Some of that is driven by access to services. And in terms of what we do to help members with that, we have we always evaluate if we get a request for a member, like they say, I need to see this out of network provider. We will actually allow the in-network level of benefit for that member to see that out of network provider if we don't know that we've got appropriate and timely services to offer to that member in lieu of that out of network provider. And we've been quite we err on the side of allowing those out of network requests rather than saying no, I'm sure we can find somebody for you. Sometimes it's, I've been seeing this provider for a long time. I know them, I don't want to switch. And so we often will approve them to use their higher in-network level of benefits, and so not have to sort of pay that network penalty for going out of network. Thank you. Yeah, you're welcome. Thanks for the question. Okay, let's look at the next slide again. And this one, again, I find a little bit encouraging, looking particularly at what's happened in the most recent plan year. What we want to see, similar to we want to see an increase
in-network utilization. We want to see increased outpatient utilization. We know that the need is there. And that's exactly what we saw from 21-22 to 2020, 22-23. We saw a pretty decent increase in outpatient utilization. At the same time, our overall inpatient utilization went down and kind of reversed trend there. And emergency department visits have been on a downward trend since basically since the beginning of the pandemic, which was interesting. Is consistent with what Kaiser was seeing. So again, if we can keep these trends up, increasing in-network, increasing outpatient, decreasing inpatient and ED visits, and we know that we're as Michelle said, we're catching people earlier in their care journey, meeting their needs better and avoiding those higher levels of care. Let's go to the next slide. So here's another one that just gives us a glimpse of how rapidly our world is changing. This compares in-person versus telehealth, both for in-network and for out-of-network. And you can see in 2018, 2019, telehealth utilization was virtually nil. And went up rapidly in the 1920 plan year. And if you think about like the first 6 months of the 1920 plan year were pre-pandemic, and then the second 6 months of that year were the height of the pandemic. So you're starting to see that switch. 2021, you're full on pandemic. Telehealth visits outnumber in-person visits quite considerably. And now as we're recovering from the worst effects of the pandemic, providers are returning to the office, and the mask mandate for behavioral health providers, for healthcare providers in general and behavioral health providers in particular, has been lifted. That makes people more comfortable in terms of, the providers not having to wear a mask all day, and more willing, I think, to go back into the office. I think members are more willing to go see a provider in person as well. So we actually just saw the in-person eclipse the telehealth for the first time since the pandemic in this most recent plan year. If you look at the out-of-network, the in-person recovered more quickly. I don't know why that is. I don't have an explanation for that. But again, you're looking at a much lower total number of visits there, but the pattern was just a little bit different there. I will also say that as we look at Behavioral Health 360, one is with the addition of Spring Health to the panel for OEB, that's going to pick up our level of telehealth utilization quite a bit because they've got amazing availability there. Kirsten, sorry. Go ahead.
Hi, Dan. No worries. And maybe you just answered my question with your comment about Spring Health, but we heard Michelle earlier on today talk about Kaiser Permanente's contracting philosophy with regard to behavioral health providers. And Kaiser mentioned they were really prioritizing in their contracting efforts, adding in-person providers to the network. So I was just curious. I mean, clearly you just said Spring Health is a virtual provider, but I was curious if Modus also prioritizing adding in-person care.
We're prioritizing adding everybody that we can add. But we are working with a lot of our providers, trying to encourage them to reestablish or to establish in the first place more in-person care. I'll actually touch on that just a little bit more in detail in a couple of slides. But it's a great question. And actually, where I was just about to go with this is the champions have a really easy job connecting people to services if the person is interested in telehealth. And for any of you who may not be familiar with the champion position, the champion position we added with Behavioral Health 360. And these are folks who are going to help members get connected to care, take the legwork away from the member in terms of finding a provider, find a provider that's available for that person, follow up with the person, make sure that it's a good fit, follow up with the person again to make sure that the services are working for them. So when a member calls a champion, we go through a screening process and identify what their needs are. If that need is for in-person services, the champions are making like 20 to 40 phone calls to different providers looking for in-person services. Whereas if what the person needs is telehealth, that's a snap. So it's definitely a huge need and going to be a continued priority. I see we're starting to run low on time. Let's go to the next slide.
Yeah, Dan, you have 10 more minutes.
10 minutes, great. I can
10 minutes. Yeah.
Easily do that. Thank you.
Super. Thanks.
Yeah. So looking at our per member per month, just looking at what the effect on cost has been, it's been a significant growth, both in the substance use disorder and mental health. But again, we're starting from such a lower baseline with the substance use disorder. Really would like to get the spend up there in particularly outpatient substance use disorder services. And I think we're going to, continue to see rising costs in both areas. Okay, let's go on to next slide and sort of zoom out, not so much the data-rich presentation, but look a little bit more qualitatively at some of what we're seeing in our environment. I mentioned early on in the presentation, there's this incredible number of venture capital-based startups, and you can sort of divide them into generalist care and specialty care. And in the generalist, we've got Spring Health, City Psychological, Sokia, they're going to be changing their name, but Mindful Therapy Group, Ginger Lyra, Modern Health, all of these new providers groups coming on that leaned into telehealth particularly during the pandemic. And a number of them are now starting to build out in-person services, and so that's something that we're really looking forward to. I've got my favorite picture of the dodo bird on the right. So all have won and all must have prizes. There's in behavioral health research, there's this thing called the dodo bird hypothesis, and what that's all about is there's like a million different types of therapy: cognitive behavioral therapy, dialectical behavior therapy, as Dr. Bachman mentioned, narrative therapy, solution-oriented, interpersonal. There's many, many different types of therapy. And what research has found that is for more general kinds of concerns like depression, anxiety, all of those different types of therapy are about equally effective. So it doesn't matter if you're seeing somebody who's psychoanalytically oriented or cognitive behaviorally oriented, probably going to get about the same results. Let's go on to the next slide. So, but that doesn't mean that all providers are equal. And some providers just are more skilled, have better way of working with people, sort of at an individual provider level. But then there are also certain things, and one thing in particular that practices can incorporate into their practice to improve their overall effectiveness, no matter what kind of therapy they're providing. And that's feedback-informed care. It's the clinical literature has shown for 20 years that this is effective, that everybody should be doing it. It improves outcomes, and by and large, behavioral health practitioners still aren't doing it. So why did we partner with Spring Health? Mentioned that whole list of generalists there in the last slide. One of the main reasons was they really integrated feedback-informed care into their DNA and use that to improve the quality of care. Also, as we talk with them, they have just a very tightly integrated program that with care navigation, and if persons test positive for suicide risk, they've got somebody onto the phone to them just about immediately. We got incredible access to services, which is actually a feature of a lot of these newer organizations. But the quality of their clinical program was really what stood out to us and why we chose Spring Health as our major partner for behavioral health 360. Let's go ahead to the next slide. Okay, so generalist care for behavioral health, one kind is pretty much as good as another. You're going to get better results if you use feedback-informed care. Specialty care is a bit of a different animal. For some conditions, we know that some types of treatment are effective and other types of treatment tend to not be so effective. So we have partnered with organizations that are doing sort of the best work in their area. There's a good organization called NoCD for obsessive compulsive disorder. There's a specific treatment for obsessive compulsive disorder that they are expert in. Anybody comes to me with OCD as their presenting problem, I'm going to recommend NoCD. They provide state-of-the-art treatment for that. A group called Equip, which provides family-based treatment for eating disorders. Again, it's easy to provide ineffective care for eating disorders. It's also very risky to do that due to the medical complications of eating disorders. Equip are experts in that particular field. Medication-assisted treatment for opioid use disorder. Let's skip over contingency management for right now. As Dr. Bachman mentioned, dialectical behavior therapy for certain conditions, including bulimia, borderline personality disorder, self-harm, severe suicidality. And now we've got, for treatment-resistant depression, we've got some new treatment options, including Spravato and transcranial magnetic stimulation for those people that really weren't served well by first-line treatments. So exciting developments really happening in the field. Let's go on to the next slide. So I'll breeze right through this. I mentioned the importance of feedback-informed care and how it's underutilized. We've established a value-based reimbursement program, which is rewarding providers for using feedback-informed care. And more importantly, really working them from a change management perspective to like, what's it take to get people to really do this and do it well. And so that's a super exciting piece of our program that launched approximately a year ago. And I'll give you two teasers at the end here, if we can go on to the next slide, in terms of some of the early results that we have from the Behavioral Health 360 program. We ask members about their experience with the program. If you're familiar with Net Promoter Score, it's become sort of a way of comparing people's experiences across industries. Anything above 50 is considered excellent, above 80 is considered world-class. So we're at excellent and working our way towards world-class in terms of our members' experience of the behavioral health champions. Next slide. And similar scores for Behavioral Health 360 as a whole, but just more in terms of their overall experience with the program, as opposed to their experience specifically with the assistance they got from the behavioral health champions. And with that, I'm going to just slip right over my allotted time. So I really appreciate your attention and time. And if there's time, according to Dr. Siltabo, might or might not entertain more questions.
Dan, I have one question for you. With the behavioral health 360 people, do we have numbers of interactions that they're having with their with clients? Is it X number a month? And is that growing? Is it stabilized? Do you have any utilization numbers on that?
Yeah, we do have some utilization numbers. It's a little bit challenging because we've just switched systems. So we've we're going to have to do a little bit of compiling, and we will get very specific data to you. I would say overall, it's looking probably more stable as opposed to growing.
Okay, thank you. Love to see the numbers eventually.
Yeah.
Any other questions from board members? All right. Okay, so we've had the two carriers provide information, and we're going to have a 10-minute break that'll take us to 3 o'clock, and then Mercer is going to come back and talk to us about their views around network standards. Kirsten, is that the plan?
Hi, Tom. Yep, that's a plan.
Okay, super. All right, and then we're going to end with the we'll end with open enrollment update. In terms of the IWG update and CIAO update, CIAO did not meet today, and IWG did not meet in January. We'll meet in, we had a brief meeting in December. And I don't know if there's, Kirsten, if there's anything that you want us to bring up for that.
I don't think so, Tom.
I don't think so either. Okay, so that's fine. So in terms of timing, what we have is we'll have this 10-minute break, and then we'll have another half hour on the open we'll have the half an hour on the network standards. We'll talk about open enrollment, and then we'll drop into public comment. So we all meet again in MAC in 10 minutes, 3:01. Thank you. I have it that it's 3:01, and so we'll get started again. What I have on the agenda is behavioral health network standards, and the two presenters are people from Mercer, Dr. Chuang, and Mr. Wendt. So Ian, you're on.
Thank you, Tom. I will start off our session and introduce Dan to everybody. He is a principal behavioral health consultant with Mercer for the past 12 years, having worked with PEB and OEBB over the past year in assessing potential gaps in the behavioral health provider network. And he has extensive experience with public behavioral health network standards and reporting. So looking forward to having him cover this section. I will kick off with a few comments to tie together what I previously discussed and what our vendor partners kind of went through, which is obviously OEBB members need and deserve quality behavioral health care. It's been heard in our retreat. It's heard through conversations that you all are having with your OEBB members. And it's also showing in the data in terms of the increasing prevalence. So it starts with a network. It starts with providing access, but access requires some standards and expectation setting, and Dan will kind of go over that. As we talk about access, obviously it starts with the provider side, but also as we're hearing, there's unique population needs, right? We have high alcohol use disorder amongst teenagers, high substance use disorder amongst the young adults. So what are their unique circumstances and preferences and what works for them? So it ends with the member. And how do we align the network and with the members and their unique needs, including practical things, right? Transportation, technology, time off. Obviously, teachers are tied to their students during the regular working day. So how do we think about alternate ways of giving them access? And the last comment I'll say about the members is inclusive of the diversity of the population and their unique needs to make sure we are inclusive as we're looking at access to all the diverse population that are the OEBB members. We also saw and heard about unique opportunities with care innovation, hugely impactful, the integration of primary care and behavioral health. That was our model when I was practicing, and it was very effective because you're handing off and connecting that body and mind care right there at the moment that the patient is comfortable telling you that. So things around that to further consider and talk about with care innovation. And lastly, I'll close with a sort of a comment about the broader picture of mental health and well-being. Obviously, the network addresses the care aspect around behavioral mental health. But as we know, with stress and burnout, it's not something we prescribe our way out of, yet it is the smoldering ash that leads to some of the mental health conditions and substance use disorders that we end up having to treat. So just don't want to leave that out of the discussion today, as it is something that the OEBB can weigh in on and hopefully influence. So with that, let me hand it over to Dan.
Great. Thank you, Ian, and thank you to the board for the opportunity to present today. So I'm going to start with this slide here with the elements of an adequate network and network adequacy or adequate provider networks. These are common industry terms to describe a carrier's responsibility to maintain a network of appropriate providers that are sufficient to provide access to covered services with the intent to meet the needs of the population that they're serving. Of course, the term adequate, we all aspire to exceed basic adequacy. We want to ensure that members can access care when needed. So what are some of the fundamentals for ensuring an adequate behavioral health network? Well, it starts with a robust cadre of practitioners and specialists that can meet the behavioral health needs of OEBB beneficiaries. It also includes enough providers based on the size of the eligible population and that can be quantified and measured through something like a provider to enrollee ratios. Another factor is the availability of providers. Our contracted providers currently accepting new members. Appointment availability standards refer to the maximum time to accommodate an appointment when requested by a member, and it can be applied to in-person and virtual appointments. It's also imperative that the Behavioral Health Network reflects the unique cultural and linguistic needs of the OEB membership as well. Other elements to consider is access to providers in terms of time and distance, and the relative ease of OEB members to get into care when needed. Some common factors to consider include maximum time and distance standards, and whether providers are available at times that are convenient to OEB members in terms of hours of operation. Other factors specific to OEB members is the ability to schedule appointments during school hours, having access to private spaces to conduct virtual appointments, and the availability of transportation to access care. The primary intent of establishing quantitative network standards is to promote timely access to behavioral health services. However, I do want to say that the evidence base to support improved access to care is limited, just based on establishing these network standards. Really, additional research is necessary to understand the degree to which network standards enhance access to and utilization of care, and to be able to identify the standards that are most effective based on the characteristics of a particular geographic service areas, such as the rural counties. There's health professional shortage areas, as we know, et cetera. There's other barriers in the behavioral health field as well that limit the ability to study the impact of network adequacy standards. And some of those other factors include a lack of consensus in defining and interpreting standards across geographic regions and service area characteristics. As I mentioned, the impact of workforce shortages on meeting standards. The lack of specialty providers can render time and distance standards challenging or impossible to meet. We have seen in other regions low reimbursement rates that limit providers' interest in joining networks. And then there's also issues with inaccurate and out-of-date and non-user-friendly provider directories that can compromise some of the standards or limit the assessment of networks just based on the information is out of date. Once we establish network standards, there's also an expectation that the administrative oversight entity will conduct oversight and monitor. And those activities can be resource intensive, and they also require personnel with requisite knowledge, skills, and abilities to effectively assess the ongoing sufficiency of your contracted carriers' behavioral health networks. For carriers doing business in the state of Oregon, I think folks are familiar with the Oregon Administrative Rule. Includes a set of comprehensive network adequacy standards that do apply to managed care entities. And we have assessed those as part of prepping for this presentation as well. So in the next few slides, we'll review some of the common quantitative network standards that can be used by administrative oversight entities and their contract carriers. Again, quantitative standards apply specific metrics or benchmarks to define and monitor access and availability of care. I think the best known one, or the most common one perhaps, is the geographic distance standards. Next slide, please. Okay, so on here, we're going to talk a little bit about one of those quantitative standards, and that is provider to enrollee ratios. Provider to enrollee ratios vary from state to state, and they also vary from different types of coverage in terms of behavioral health, but also different types of programs. And so we have pretty well-established standards that we can draw from the Medicaid program. Medicare Advantage has established some standards along with geographic areas that they define. And then I mentioned that the Oregon Health Authority has utilized the administrative rules to define at least expectations around provider to enrollee ratios. They don't specify what those ratios are in rule, but they do require managed care entities to collect and actively monitor data on provider to enrollee ratios. And I believe in previous presentations, we've heard from the carriers that they in fact are doing that type of work. This table here on the slide just highlights some examples of provider to enrollee standards. These particular ones came from a different state Medicaid program that actually does explicitly specify what the ratios or ranges need to look like across certain types of practitioners. As you see, you've got the psychiatrist, and these are one psychiatrist to every 1,500 to 2,000 enrollees, and then the ratio for clinical psychologist, licensed clinical social worker, and marriage and family therapist. While provider capacity to see patients is critical and necessary, and I think we heard this earlier in one of the presentations, members also have to have the ability and the means to be able to attend appointments. Is there a question? I've been.
Yeah. This is Tom. The ratios that you have there don't make sense to me because number one, they don't differentiate whether or not the provider is someone that is 100% committed to a plan versus to let's say where there's 10 plans in the area. So a ratio makes sense if it is related to a population that that provider is committed to provide. So let's look at the difference at in Portland. If you had a psychiatrist that's part of Northwest Permanente Medical Group for Kaiser, that psychiatrist is seeing 100% Kaiser patients. If you look at a psychiatrist in Bend, that person may, she is caring for MOTA members there, but she's also providing care for Regents members and for everyone else. So the way that those numbers lay out are pretty useless from my perspective because they don't tell you what percentage of that provider's time is committed to that particular plan.
Yeah, I think that's a great point, Tom, and thanks for drawing attention to that. I think these ratios are based on what's been negotiated between in the contract between, in this instance, the Medicaid agency and their contracted managed care organization. So I think the intent is that managed care organization would have a psychiatrist available at that ratio for that payer's population. And so not to say that psychiatrist may not be treating or be part of a different network or involved with other carriers in terms of their network. But for what they're purchasing, the managed care organization needs to ensure that they can see 1,500 of their members. And that's where the ratio, how the ratio is established.
Okay. It would suggest in Oregon we'd need 3,000 psychiatrists, and my guess is that we have 1/8 of that number.
Correct.
That's a guess,
well,
but it
point well taken, though.
In the ballpark.
Okay. Good discussion. Thank you. Okay, if we could move to the next slides, I think it's slide 6. Okay, so here, this is a metric around providers, or a minimum percentage of providers that may be able to accommodate new clients. Again, another quantitative metric that can be used to measure network adequacy and provider availability. Some of the accrediting bodies require organizations to either report the ratio of each type of behavioral health care practitioner to the number of members, which we just previously covered on the prior slide, or the ratio of each type of behavioral health practitioner that's accepting new patients to the number of members. We see less of this standard being applied. It's less common. However, Medicare Advantage and many of the Medicaid programs do need to denote which providers are not accepting new patients in their provider directories, and those typically have to be updated at a minimum each month. As you can kind of, if you think about some of the time and distance standards, you may have a particular provider in a geographic area that's available to your membership. But if that provider at some point has turnover and or other issues that prohibit it from accepting new members for a period of time, then you can see that the time and distance standard might be checked off. But if the provider is not actively accepting new patients, and then that's a different issue altogether. So this tries to get at a kind of a different level and be able to assess that. As with the prior metric, the provider to enrollee ratios, you may elect to restrict that application to what's referred to as high volume providers. This requires you to kind of be able to define the types of high volume behavioral health providers and establish measurable standards for each type of practitioner, as well as standards for geographic distribution, because you're going to have different standards based on how dense the population is, for, for a rural versus an urban area, for example. And then these are typically analyzed. The performance on this is analyzed typically on an annual basis. Some examples of high volume providers may include psychologists, clinical social workers, marriage and family therapists, substance use counselors, addiction medicine specialists, and even psychiatric clinical nurse specialists. So Medicare and Medicaid, as I mentioned, usually include this information about accepting new referrals in their provider directories. We've seen some states, Connecticut, for example, that require at least 70% of providers to be accepting new patients at any given point in time. Some states have set a minimum limit for the percentage of providers who are not accepting new patients at a given point in time. Again, this can be specific to the carrier, density of the geographic service area, and or the practitioner type. The availability provider should also incorporate concordant providers to meet the unique, diverse race and ethnicity, gender, and clinical needs of your membership. Next slide, please. So here we're going to discuss a little bit about maximum wait times for an appointment. This is also sometimes referred to as appointment availability standards. And depending on the severity of need, wait times can present significant risk to members' health and well-being if they are not able to access care timely. The table here is indicative of the current Oregon Medicaid wait time standards. And these are maximum wait times for an appointment, broken out by type of service. We have your behavioral health routine appointments or an appointment for an initial assessment within 7 days of request. A second appointment for behavioral health as clinically appropriate, but typically we want to see that within 14 to 21 days for sure. Behavioral health urgent appointments within 24 hours, and then opioid use disorder treatment to do initial appointments within 72 hours. Next slide, please. On this slide, we're going to discuss a little bit about time and distance standards. I've mentioned this. This is the most common quantitative standard that's currently in use. It's typically evaluated through software that plots available providers or contracted providers against the carrier's enrollee's physical location. These maps produce evidence that the carrier has sufficient providers to meet established time and distance standards. Again, I mentioned this can be misleading if these providers are no longer active in the carrier's network. It's not a static thing, as you know, they can drop off the network, or as I mentioned, they may not be accepting new members due to capacity limitations. A little bit more about this standard. It's essentially how long will it take to travel to see this provider. So it doesn't necessarily factor in the availability of telehealth, which we've really established today as here to stay, and its prevalence has definitely been demonstrated since the pandemic. And then Oregon Medicaid has defined time and distance standards based on, again, population density, and they've defined large urban and rural and county with extreme access considerations. Those are all defined in rural, and you can see the corresponding standards that are established for each of those geographic types of areas. The next quantitative standard I want to address, please move to the next slide. And this has to do with operating hours. And these specify when members should have access to behavioral health services apart from emergent and urgent services. So for more routine care. There's not many states that have really adopted standards that include expanded hours of operation, which would include evening or weekend hours. A lot of times the language is that the services must be available comparable to other plans, commercial plans or medical assistance fee-for-service standards. Or consistent with normal business hours, or even more generic, meeting the needs of the eligible population. Arizona has broadly defined this as reasonable access, but also state that services should be accessible during normal business hours or sooner if medically necessary. And California requires providers to have extended hours at least 1 day a week or for 4 hours on Saturday. So there's different approaches that can be adopted here. For Oregon Medicaid, the managed care entities must collect and actively monitor data on provider hours of operation, but they don't specify what those hours need to be. Next slide, please. So this is just to note that there are issues with addressing barriers to care. This can include several things, including social determinants of health, technology. Do members have a private space for making and attending appointments? Is there dependent care available while attending appointments after work? And the issue with transportation is a real barrier in terms of being able to access in-person appointments. Next slide, please. So once the standards are established and defined and conveyed to your carriers through contract, then you need to go about the business of monitoring those network adequacy standards and management activities. You know, there could be an annual report to the board on the state of behavioral health network adequacy. Oftentimes we see carriers reporting on the tracking and trending of complaints and grievances specific to access to care issues. There's been increased interest recently in secret shopper surveys, or what's referred to as proxy calls, where you call providers and ask for when their next available appointment is. CMS has actually put this activity as a requirement or potential requirement in a proposed rule that's expected to take effect later this year, where states and MCOs will be required to conduct secret shopper surveys. We've seen data today on the monitoring of service utilization trends, which would be important to track over time. Are services available in alternative settings like schools? There are specific access to care performance measures that can be tracked. Results of member satisfaction surveys related to experience with timely access to care, or having a third party come in and do an independent assessment. And I think Ian has mentioned the importance of integration of primary care and behavioral health and tracking the use of Z codes. Next slide, please. So here we talk about the workforce shortage and contracting challenges just based on the lack of available providers. This is pretty well established, and I think everybody is pretty well aware of this. There's issues with providers panels being full, low reimbursement rates in certain areas or for certain practitioners. Providers may not want to participate in a particular network due to perceived administrative burdens or perceived delays in getting paid. There's definitely estimates and current shortages of psychiatrists and substance use counselors and other practitioners, as we have listed here. It'll be important to build, you know, a robust behavioral health workforce that's representative of the community being served, and can provide culturally responsive services. And there's strategies to increase the supply of providers through things like tuition reimbursement, internships, clinical placements, and other initiatives related to scholarships. Next slide, please. So this is my last slide, I believe, and it's just a proposed timeline of potential activities for next steps. You know, today we're kind of talking again about the work, the options and the potential for establishing some behavioral health network standards. And then later this year in May, maybe present proposed standards and reporting metrics. We could begin collecting data as soon as the summer of this year. And then there's been discussions about performance guarantees around reporting in the 2024-2025 contracts. And then just carrying that over to year 2, continue to report results and discuss findings, present proposed targets, and then look again at reassessing the performance guarantees and establishing a longer term roadmap for years 3 and 4. At this point, if there's no other additional questions, I'll go ahead and turn it over to my Mercer colleagues to finish up today's presentation, and thank you.
Thanks, Dan. Hey, Tom, I just wanted to jump in for a minute and do a time check because I know the time allotted for this presentation is, I think, pretty much up. I was going to check and see if we had
Let's
2 or 3
continue
minutes.
another. Let's continue another 2 to 3 minutes because I think that that the board, have seen, this. We need to know that it's going to be moved forward and carried forward. And Dan laid out a plan. My memory is that these behavioral health network and adequacy, network adequacy, it was one of the things that the innovation work group was working on. And my sense is that what works for OEB would also work with PEB, and it would seem to be the natural place to continue this discussion. What are your thoughts? Is that Mercer's thought or something different?
Hi, Tom. That's right. I've been talking with Emery and also Margaret about this as well. And the Behavioral Health Network Standards is on the IWG work plan. So we'll just plug OEB into that effort. It could be a joint effort.
Great. And what was interesting was, Dan, you ended up talking about routine appointments within 7 days. When just the previous, hours, we heard from Kaiser Permanente talking about routine within 10 business days, and I think there was some link to NCQA. So there was a standard that sounds like was different than what you were talking about, and we didn't hear anything from MODA about what their monitoring and standards are for routine appointments. So it shows that we have lots of gaps and kind of unfilled spots here. So coming up with something that we as a board feel is appropriate measurement for our plans to be able to monitor something that we all agree is very important for our membership. So, we have work to do here is what I'm trying to say.
Thanks, Tom. We think so too. So it sounds like, Ian, you have a couple minutes to walk through burnout.
Thank you. So I wanted to close by just, again, addressing burnout because we heard it at the retreat. We're hearing it from the OEB members. It's a physical, emotional, mental exhaustion that accompanied by decreased motivation, lower performance, and negative attitude towards oneself and others, including the organization. So huge impact ramifications. That being said, it's not something that's easy to address. Obviously, there's macro factors that create this dynamic and experience of stress and burnout. We can't change that. The question is, what can we do within the OEB organization, the schools, etc. So on behalf of OEB and PEB, Teresa Cross is collaborating with the Oregon Department of Education to look at that and map some efforts across the state to support employee wellness, well-being, and resiliency. And culture is important, and so is leadership. So that can have a tremendous impact in terms of how the employees, the teachers feel. Like I said, the macro issues we can't change, but the question is how can we optimize the experience? Next slide. So some things that may be under consideration, because here's the contributing factors, and we know these well. These are not the only ones; they're the main ones: workload, life events. Work demand, information overload, parent-teacher challenges. Their own personal caregiving duties, and their own physical health and well-being. So a lot of these things are impacting our teachers and OEB members. And so some of the things that will be looked at by Teresa Cross includes, what can we do to really create an environment that says, hey, we recognize this, we can't solve the macro, but here's what we can do to improve the experience and the work environment to help a bit on the work front. So that's all I wanted to say, and we'll look forward to hearing back from Teresa on that progress. That is it. Kristen?
Great, thanks so much.
That's great.
So that's it for the Behavioral Health Network Standards presentation, Tom. We just have the open enrollment update from Mercer left.
Okay.
Great, so we're just going to briefly, yeah, thanks, Tom. We're just going to briefly walk through some open enrollment highlights. We tried to use minimal data tables and graphics wherever we could, because we recognize it's the end of a long day for all of you. We really appreciate your patience hanging out with us this afternoon. There are just some data notes. I wanted to get them out of the way all up front, and that way we don't have to worry about them as we go through. But with any data project like this, we're really fortunate to get census files from OEB for September of 2022 and, it should say September of 2022, or no, sorry, September of 2023 and November of 2023. So we could look at the change in enrollment between the 22-23 and 23-24 plan years. These are big Excel spreadsheets, so they had just some data anomalies that we needed to walk through, and that's what is documented here. Just a couple things I want to call out. In the data that we're going to look at, we're looking at active employees, retirees, and COBRA enrollment. We are not including the self-pay retirees and their dependents in this look. And then a couple other things. What's in the census file, those are employees employed by the entities who were offered coverage and their coverage decision. So what from that, we can glean certain things like Corvallis School District has employees who are enrolled in Kaiser Plan 2A, MODA 3, and MODA 5, for example. We've made an assumption that those are the plans being offered to the employees. It's possible that the employees are being offered some of the other plans and there's no enrollment. And we're not seeing that, because what we're seeing are the election decisions for the employees in the census file, not what the entities have decided to offer as their full benefits portfolio. So that will come up. We are also, because this is a census file at the employee level, when we talk about geography, rural versus urban, or some of the other more granular areas within Oregon, that's based on the employee's own personal zip code and not the zip code of the entity that the employee works for. We're going to have one more slide kind of setting the stage for today that's going to talk about some of the special populations within OEB. Senate Bill 551 is one of those populations. Also, there's local government. Okay, I think that's it for this slide. So Rose, let's go forward to the next slide. And once we get through this, then we'll just jump right into the data. So this is special enrollment. Just to make sure that we're all familiar with these terms, we wanted to just talk through them briefly. So Senate Bill 551 was implemented October 1st, 2021. And extends OEB medical coverage to help part-time faculty at Oregon community colleges and universities qualify for insurance. And then it was recently expanded to include dental and vision as well. The local government program allows, I can call them entities as well, but it allows other groups beyond school districts to enroll in OEB. And there's a financial check at the underwriting process that says, hey, do you guys look like a typical OEB group, or do you look like your claims are way more expensive? If the group looks way more expensive, to protect OEB, the group comes in at a higher rate. And then after 3 years, they go back to the normal base rate. So those are called local governments. And in subsequent slides, we'll see them called out as LG. And then just as a refresher, we have out there a bronze plan. We don't talk about it very much, but both Kaiser and MODA offer a bronze plan. It's called the bronze plan because it ties to the Affordable Care Act, which calls all of its different benefit richness levels by metal tiers. So the bronze plan picks up 60% of the plan's cost. It's paid for by the plan, 40% by the member. So, I mean, if you compare that to a typical OEB plan, where some of the plans might have 20% coinsurance or just a small copay, it's a leaner plan. But then the benefit of the leaner plan design is it's more affordable. So sometimes we have some enrollment in these plans, sometimes we don't. But that's been around. We'll see that. I think there's a Kaiser enrollee on that plan, and it's limited to just employees and their children, not spouses or partners. All right, so we got through the weeds. So let's start looking at some results. Rose, next slide, please. And one more. Thank you. So great news. And we're really happy to end on a positive note today for you all. So OEB grew in all 3 lines of coverage: medical, dental, and vision. And in the rest of the slides, we'll look at the data through a couple of different lenses and then also touch on some major drivers. For medical, the growth was 2.2%. We saw that in both Kaiser and MODA. The dental growth was even a little bit bigger, 3.2% growth. All the carriers grew. And then there was 3.7% vision growth. VSP had higher growth than Kaiser and MODA, but they all grew. All in for medical, we had 56,214 subscribers. Remember, that's active employees, retirees, and COBRA enrollment, not self-pay retirees, but about 56,200 subscribers as of October 1st. Roughly the same amount enrolled in dental, and then slightly less enrolled in vision. Rose, next slide. So of the medical plan types, we have 3. Kaiser offers the choice of an HMO plan, plans 1, 2A, and 2B. Kaiser also offers an HSA plan, that's plan 3. And then MODA offers plans 1 through 5 are the PPO plans. And then there's 2 HSA plans, 6 and 7, and the bronze are HSA as well. So this is just looking at PPO versus HSA versus HMO. Did we see any enrollment trends here that are interesting? So the PPO and HMO plans are leading the enrollment growth this year. The PPO products had 76% of the enrollment growth, and the HMO products had 26% of the change. That adds up a little bit to more than 100 because of the -2 on HSA. So to keep it simple, we can just think of 75 PPO, 25 HSA. The plan mix stayed fairly consistent. So looking at all of the enrollment, 54% enrolled in a PPO plan, 27% enrolled in an HSA, and 19% enrolled in an HMO. We have behind that also Kaiser's more limited service area versus MODA's statewide plan. So that's definitely a factor in that mix. Rose, next
Kirsten,
slide.
I think
please.
that you just, Kirsten,
hi,
I
Tom.
think you reversed those numbers. You ended up saying the HSA was 27% and HMO was 19. I think those are reversed because the HSA is smaller than the HMO.
Yeah, it's true, Tom. Thanks. Yeah, you're correct. I'm looking at my spreadsheet about that.
Just, yeah, okay.
Yeah, thank you. So looking at the dental plans, we were asking ourselves, what's interesting here about dental, and noticing that the majority of members within OEB are interested in the ortho plans. So overall dental growth was 3.2%. With ortho grew 1,136 subscribers, and the plans that don't have ortho grew by 624. The plan mix stayed fairly consistent at 82% of people enrolled in a plan that has ortho, compared to 18% enrolled in a plan that does not. Rose, next slide. So let's talk about some of the reasons for the enrollment growth. The Willamette Valley leads the enrollment growth, and we'll dig into exactly why here in the next slide. But we can see We've called out 3 regions that had the largest amount of growth: Willamette Valley, Metro, and Southern I-5. And then the remaining OEB regions are grouped in the other category. They're called out very specifically on the first slide if you're curious about what's in there. So for Willamette Valley, we had a medical enrollment growth of 508 subscribers, 947 subscribers in dental, 927 subscribers in vision, compared to like 432 to 477 in Metro, and 167 to 244 in Southern I-5. And we'll see on the next slide that that's primarily due to the Corvallis School District. The Corvallis School District did 2 things on 10/1/23. So the teachers joined OEB. So 79% of that Willamette Valley growth was due to Corvallis. And then also at the same time that the teachers joined OEB, Corvallis opened up dental and vision to everybody, which is why that dental and vision increase was even bigger than the medical. So that's the middle section there. Willamette Valley dental growth, 83% of that was Corvallis. And then on the vision, 81% of the Willamette Valley growth was due to Corvallis. And then just in general, you know, we looked at the other entities, and it just looks like to us, and I think you all as the board would be in a better position to confirm this too for us, but it really just looked like enrollment was up across the board, maybe following increased hiring as well. Rose, next slide. Oh, hi, Robert.
Okay.
Robert has
Hi,
a question.
Kirsten, I have a question. The Corvallis School District, by entering into OEB, are they treated like an LG with the surcharge, or are they not?
Oh, they are not treated as an entity that would get the surcharge. They're specifically called out who in the local government's provision who qualifies for that, but the Corvallis is just normally eligible for OEB.
Yeah, we have separate rules for local government participation. Part of that's an underwriting.
Susan Miller.
Yeah, there's another question.
Thank you. It's a side note, but as you all know, I represent the Oregon School Employees Association, and we're trying really hard to expand the term away from just teachers to say educators in the system. So I just wanted to draw attention to that, and it would be appreciated because we feel left out, classified feel left out frequently by just referring to teachers. Thank you.
Thanks, Susan. We really appreciate that comment. We'll make sure to do that from now on. Rose, next slide. So, oh, thank you. Senate Bill 551, we learned is a Senate Bill 551 extended OEB insurance to certain part-time teachers to help make insurance more accessible. So we're just taking a look at the Senate Bill 551 enrollment to see if it was a major driver in the overall medical growth. And it was a very, very small portion of the total medical growth. So just about 1% of that 2.2% medical growth was due to Senate Bill 551 year-over-year growth. So an additional nine subscribers on the medical, more on the dental and vision. Again, that coverage was expanded, so that makes sense. But about 2% of the dental growth and vision growth was due to Senate Bill 551 enrollment. And they're on the same rates. They're on OEB base rates. There's nothing different there. Rose, next slide, please. Great. Enrollment by plan, we just felt compelled to include at least one data table so we could take a look. Similar things that we've seen here before within Kaiser. The majority of Kaiser subscribers, they really like Plan 1, Kaiser Plan 1. And then within MODA, there's a pretty even distribution of enrollment between plans 2, 3, and 4. And then collectively, if we combined 6 and 7 into one, you know, and thought of it as an HSA plan, it would have the most enrollment. The LG there just means there's a little bit of local government enrollment. And this is Coos County that is still in there for 23-24. Rose, next slide. Great, so now we're taking a look at medical enrollment as well. So now we're looking at all the regions. A couple of slides ago, we looked at the Willamette Valley, Metro, Southern I-5, and all other combined. And this just shows a little bit more detail about all of the different regions. So you can see why they were ranked that way. In the third column over, change in enrollment, there's Willamette Valley with 508 additional medical subscribers. So that's the largest change in that column, followed by the metro area at 432 and Southern I-5 corridor at 167. The largest OEB region, now looking at the November 2023 enrollment column, the largest region is Metro region, here in the Portland metro area, followed by the Willamette Valley, and then after that also the Southern I-5 corridor. And then the other regions include Central Oregon, the coast, Northeast Oregon, and Southeast Oregon. Rose, next slide, please. Similar dental enrollment by plan. Kaiser and Willamette Dental each offer one plan. So Kaiser is at about 8,300 subscribers. Willamette Dental is pretty similar, 8,100 subscribers. And then if we look at Delta Dental, they have a couple different plan types. An EPO, so that's exclusive PPO. An EPO has a smaller network of providers than the PPO plan because it does not include access to out-of-network providers. So Delta Dental has two of the EPO style plans. They just have different benefit designs. Together, those have about 3,800 subscribers. The Premier Plan 1, which is one of the original Delta Dental plans, by far has the most at 18,500 subscribers. And then plans 5 and 6 together have another 18,000 subscribers. Rose, next slide, please. Here's just a visual of the distribution of dental enrollment by plan. We can see about 70% of enrollment is in the Delta Dental plans and about 30% of enrollment in managed care plans with Willamette and Kaiser. Again, keep in mind different service areas is a factor here, in addition to just having a different preference about benefit designs. There's either really the copay limited network design or more of an open panel coinsurance design with Delta Dental. Rose, next slide, please. Vision enrollment by plan, again, very similar to dental, Kaiser and VSP. Well, Kaiser offers one plan design. VSP has two designs, actually, Choice and Choice Plus. And then MODA has three that vary by benefit maximum. Kaiser's enrollment now is about 9,000 subscribers. MODA's enrollment in the Opal, Pearl, and Quartz plans about 27,000 subscribers. And then VSP, the VSP Choice plan actually had the highest growth overall between plan years, grew 10.2%, and now it's at 12,300. And we'll see the distribution for vision on the next slide, please, Rose. So about 50% of the enrollment is in the MODA plans. At this point, over 30% in the VSP plans. Kaiser has 17% enrollment in the vision. We just have just a couple slides left. Rose, if you, take a look at this one. So, one way to look at migration is to map everybody and say, okay, what plan were you enrolled on in September? What plan were you enrolled on in October? And you make kind of a complicated little grid that way. But we just wanted to ask ourselves, okay, but what's the takeaway of this? Our members, like what is the main decision that members are making? Are they moving? And if they are moving, where are they moving to? Because really that's what we're thinking about at our renewal decision. And and you could see for medical, dental, and vision, roughly 90% of employees stay with the same carrier. So if they renewed, meaning they didn't opt out of coverage or drop off the plan altogether, 90% of them, 92 for medical, 87 for vision, but about 90% of them renewed with their same carrier, which I was surprised and not surprised at the same time. I knew it would be high, but 90% just still seemed high to me.
Now,
and then Rose, go ahead, Tom.
Kirsten, the disenrolling, majority of those people who are basically leaving employment, and going somewhere else. That may be retirement. It may be going to a different entity and they'd be counted in a different way. Is that correct?
So in this setting, I also needed something to do with the people who were enrolled and then opted out. So in this particular setting, disenroll means either they went to opt out or they just terminated coverage altogether. So either way, in November, they're not in, or in October, they were not enrolled, but in September they were. Rose, next slide, please. So now looking at those people, so 92% of employees stayed with medical with their same carrier. So if we look at just those employees only, sometimes you hear the term buy up or buy down. And what we mean when we buy up is that we migrate into a plan that has richer benefits than the plan a member is currently on. Maybe they do that because they anticipate having more healthcare needs or because they have an increase in their contribution from their entity. Also, they could buy down. Maybe they have dependents joining, or they don't anticipate needing care or other constraints. They want to prioritize dental and vision. So they might move into a leaner plan. So here we're just taking a look at employees who renewed with their same carrier. Did they stay in the same plan or did they move either way? The vast majority actually stayed with their same plan. And there was really no trend for people who migrated. About the same amount moved into a richer plan as moved into a leaner plan. But again, by far, people stayed mostly with their same plan. Rose, next slide. And I just want to reiterate something while we wrap up these couple of slides that I mentioned at the beginning, which is we're talking about employees valuing entity choice. It's possible that the entities are offering more plans even than what we're showing here, because we can only capture it if it's attached to an employee in the census. If it's a plan that's offered but not attached to any employee, we wouldn't know that. But even that said, 90 out of 253 entities offer Kaiser medical plans, presumably because they're in the Kaiser service area. Looking at those 90 entities, 77% of them, so Kaiser is the light blue, 77% of them offer at least 3 Kaiser plans. And then 39% of those entities actually offer all 4 Kaiser plans. So you'll see this as a trend. If an entity offers a carrier, they tend to offer many plans from that carrier. And then the same information for MOTA. So MOTA are the purple bars. And I should have mentioned across the bottom, that's the number of plans that are being offered by that entity to its employees. All 253 entities offer the MOTA medical plans. And again, remember, there's a difference in service area. MOTA is statewide. Entities can choose from 7 MOTA plans, plus the bronze plan actually makes 8, but there is no MOTA enrollment. Just looking at those 253 entities that chose to offer MOTA, 85% of them offer at least 3 MOTA plans. And very similar to Kaiser, 38% of the entities offer all MOTA plans available. This was a really clear signal to us from the census just how much OEB entities and employees value having the choice of portfolio that OEB has. Rose, next slide, please. Similar, we're looking at dental choice here. Again, there's a difference in the number of entities offering Delta Dental versus Kaiser and Willamette Dental just due to service area. But even then, 251 entities offer at least 1 dental plan. All of them offer Delta Dental. 79% of those offer 3 or more plans. And then 86 out of the 90 entities offer Kaiser Dental. 192 entities offer the Willamette Dental plan.